I'm Lisa Bundy. I'm one of the faculty members at Magnolia Regional in the Emergency Medicine Residency Program. So this was a really interesting case that we had, and it was late at night. We had a patient come in about, she was in her 50s, had mitral valve replacement 2 weeks prior. And she came in and in the field from EMS, she had no blood pressure. They couldn't palpate anything. So of course, her protocol, they start fluids, thinking she might be septic or what have you. As she was altered, cold, clammy, she was in shock. She was somewhat responsive. She's got edema and she's in respiratory distress. So basically, as soon as she came in, I'm the ultrasound director, so we went in and ultrasound it, did an echocardiogram, and it found her to be in cardiogenic shock. She had a very low ejection fraction. Our EPSS was greater than 15, which is indicative of severely depressed ejection fraction. She had a very dilated IVC. And you can actually see in the first image, it actually dilated all the way up into the hepatic vein. And she actually had backflow into the hepatic vein when we used pulse wave Doppler on it. As soon as this was discovered, we stopped the fluids and started her on Levophed and dobutamine. She had a myriad of procedures, art line, central line intubation. She actually got a pneumocath because she had a huge right-sided pleural effusion. And so by the time she left and we transferred her back to the facility where she had her surgery, her systolic blood pressure was 130. So we were able to, and she was starting to kind of like pink up and look a whole lot better. So she had cardiogenic shock. Basically this is undifferentiated shock. So when you have undifferentiated shock, the ultrasound or point of care ultrasound is extremely valuable in these situations. You can determine if they have cardiogenic shock, distributive shock, hypovolemic, and of course in trauma, hemorrhagic as well. So this actually really changed the management of this patient, because typically without this, we might have kept pumping fluids in or thinking she might be septic or what have you. And with the sepsis protocols that are kind of hammered into us, that's what we think automatically. But in this patient, it would have drowned her. So it made a huge difference in the very immediate care of her. I think we had changed everything over within about 5 to 10 minutes of her coming in. So that was that's basically her, that was basically her presentation and what we were able to do to stabilize her and get her ready for transfer, especially in a rural emergency department, where she didn't have her surgery or anything like that, to get somebody stabilized, to get them transferred. And that's very, very important. So, does anybody have any questions?
I might have missed it, but how far post mitral valve replacement?
2 weeks.
2 weeks.
About 2 weeks. And at first, the surgeon didn't want to take her back, and we were like, "No, you're taking her." So anyway, you can actually see when I reviewed the images, you can actually see the valve in question a little bit. It's a little bit hyperdense or hyperechoic on the ultrasound. So,
Any idea how fast the onset was?
I think it was rather sudden. I think she'd been like kind of short of breath for a few days. We didn't get a whole lot of history because she couldn't tell us. Couldn't tell us anything. And her family wasn't there yet because we got her out. I think we got her transferred within an hour or two. So we got her in and out pretty quickly. But I believe it was pretty quickly. And that's actually a good question, because if you've got sudden onset shortness of breath, you can also use supportive care ultrasound, not only determine it in echocardiogram, but with the echocardiogram, you can look for B lines on the lungs, which indicate pulmonary edema a lot of times. And it can guide your care that way too. So, yes. Yeah. I do have a butterfly. It's a little bit old, but we have a GE venue in the department. We are currently requesting an ECMOS and capital. We're currently requesting another device because as of this year, emergency medicine residents are required to have 300 scans for graduation. So there's a lot of scans. It used to be 150, now it's 300. Yes, yes. So my students actually use something called Foundations, which is on not Foundations, anyway, it's on coreultrasound.com, and it's kind of geared towards interns and medical students. So that's very helpful. And then we do, once a month, we have lecture on the different ultrasound topics throughout the year. And then once or twice a year, we'll have like a whole day where we do like a hands-on thing, but they're encouraged to scan constantly in the department. So usually we can't find the machine, which is means somebody's got it. Sure. Yeah. So any emergency medicine boarded physician, especially coming out within the last 10 to 15 years, will have had an ultrasound or some basic ultrasound training. When I graduated, it was in 2010, it was like was fast and maybe some gallbladder stuff and that kind of thing. In the last 10, 15 years, it's expanded to just about any part of the body. So eye, musculoskeletal, all that stuff. So we go through all of that. And a lot of times what I recommend is people maybe just doing an online, you can do an online course, or you can do, there's workshops all over the place to get some like basic hands-on, like if you're not really familiar with it. A lot of internal medicine doctors are doing those kinds of things, especially as hospitalists, because that's very helpful for them, especially if they're working at night and they want to make a diagnosis, they have a patient that's in trouble and they want to try to make a diagnosis. So, yeah, it's actually the studies have shown that actually there's a study that shows an echocardiogram after a certain amount of training, like 30 minutes of training and a certain amount of scans, an emergency physician can make a very accurate determination of an ejection fraction, just about as accurate as, as a cardiologist or whatever, especially point of care. So.
Thank you.
Okay, thanks.